Thank you very much for the kind introduction. One of the things that I want to mention before I start is that I'm actually born and raised in Bombay, and I did my BDS and MDS in Bombay before I moved to the US. So it's like a homecoming from me, and it's truly an honor and privilege. So the topic for today's presentation is biologic complications of the third dentition, their diagnosis and management. Just as a disclosure, I have no financial support from any company or any of the products. I have no known conflicts of interest, and I have not used Photoshop anywhere. So just to discuss briefly complications related to implants. They're broadly divided into surgical phase, restorative phase, and during the maintenance phase. Surgical phase, we know it could be during the preoperative time, during the actual procedural time, or actually post-operative. And restoratively, we've noticed that there can be problems because of malposition, mechanical problems, phonetic problems, or aesthetic problems. And in the maintenance phase, you can have mucosal disease, which is peri-implant mucositis, and inflammatory disease, which is peri-implantitis, which is what is going to be the focus of today's presentation. And there can also be loss of stability of the restorative components, screw fracture being one of the main ones. So what are the reasons behind these complications? I believe that the following are the few reasons why we are seeing that. Obviously, we have noticed that the total number of implants being placed has drastically increased over the last 10 to 15 years. There's also an increased number of dentists that are placing these implants, and they have different levels of experience. Until very recently, there was no formalized training in dental schools. The only courses that were being offered were by implant companies. And a lot of those company-sponsored courses would say that the implants have very high success rates, and again, you know, the definition of success is it functioning or is it really successful? And also what we have seen is a trend where dentists are placing implants in compromised sites by using very aggressive protocols. And that's probably what's causing a lot of the complications. What we've also seen, and I've agreed with this, is implant complications tend to occur either in the first 12 months or they occur after about 7 to 10 years. So as they say, if you move your practice every 7 to 10 years, you'll never see a complication. But if you've been in practice long enough, you'll see it. Dr. Homle Wong, who is a well-known publisher and researcher based out of Michigan, has said that this is his personal opinion of what are the most common implant complications. And the number one is that the implant is placed in the wrong position, and you can see what that is. But number two and number three, which is our focus for today's presentation, is residual cement and peri-implantitis. The key point to remember is the more complicated the case, the more the potential for complications. Dennis Tarnow famously says, try to do one miracle at a time. So don't try to achieve too much in one procedure. Take it step by step. So let's go into detail about biologic complications. And we see a lot in the practice nowadays. It's really on the increase and on the uptake. So before we go into any more details, just to have definitions of what it is. Peri-implant mucositis is a disease in which there is inflammation, which is confined to the soft tissues surrounding the implant, but there are no signs of loss of supporting bone. And that's a key point. The only loss of bone you might see is what the initial remodeling is during healing. And sometimes it has been referred to in the literature as an ailing implant or even hyperplastic mucositis. Peri-implantitis, on the other hand, is a site-specific plaque-induced infection with progressive bone loss, but the implant is functioning. So that's the key difference. So what about the prevalence? How prevalent is this disease? So most outcomes from reports, which are basically meta-analysis, have said that the prevalence of peri-implant disease is almost up to 48% of implants, followed for 9 to 14 years. However, they also state that because peri-implant mucositis is reversible with early intervention and removal of the etiology, it is possible that this prevalence is underreported. As far as peri-implantitis, the numbers are all over the place. One study had about 7% in 9 to 14 years, another one said 23%, and there's a third one that even reported almost 37% at 8 years. And the reason why these numbers are all over the place is because initially we did not have a system for how do we classify this disease and what kind of parameters do we use to diagnose that it is peri-implantitis and then how we can treat it. And therefore the numbers, that explains the variance in reporting the prevalence of this disease. As far as etiology of these complications, we know that the description of the inflammatory process of peri-implant mucositis is similar to gingivitis around the teeth. So it's our good old friend plaque that does it. Shortly after the implants are placed, the glycoproteins from the saliva adhere to the exposed titanium surfaces with concomitant microbiological colonization. So same thing that you see, and then eventually there's a biofilm, and this biofilm is very important and plays a significant role in the initiation and progression of this peri-implant disease. It is generally accepted that peri-implant mucositis is the precursor of peri-implantitis, just like it is accepted that gingivitis is the precursor of periodontitis. However, similar to the causal relationship between gingivitis and periodontitis, peri-implant mucositis does not necessarily progress to peri-implantitis. And the reason they feel is because peri-implantitis, like periodontitis, occurs as a result of an overwhelming bacterial insult and the host response to it. And the bacterial species are similar in periodontitis and in periodontitis. However, new research has shown that Staph aureus is also an important pathogen in the initiation of periodontal disease. The markers, the familiar pro-inflammatory cytokines, the IL-1, IL families, the tumor necrosis factor families, are also all upregulated in peri-implantitis. However, the rate of disease progression and the severity of the disease in peri-implantitis is usually different than periodontitis. And the reason for that is that the increased susceptibility for bone loss around implants is related to the fact that there is an absence of inserting collagen fibers, as is the case with the tooth. So a recent comparison of both periodontitis and peri-implantitis noted that there was a self-limiting process in the soft tissues around natural teeth that resulted in a protective connective tissue capsule of supracrestal fibers. Whereas the same authors went on to note that such self-limiting does not occur in peri-implant tissues, and that the lesion extended to the bony crest, which was different than in periodontitis. So again, this is a schematic from Lou Rose's textbook of periodontics. The slide on your left, the picture on the left rather, is showing you the tooth, and you can see the supracrestal fiber attachments that are present on teeth, not so much on an implant, and therefore you tend to see more bone loss around implants and in peri-implantitis. What are the risk factors for some of these biologic complications? Previous periodontal disease, poor plaque control or inability to clean the teeth, residual cement, smoking, diabetes, occlusal overload, and also there are some new potential emerging risk factors, including some genetic factors. The ones that I believe are the most important and that I've seen in my practice is poor plaque control or inability to clean, residual cement, and smoking. So let's look at this patient. She had some implants done in the practice prior to my taking over, but the lower anterior was failing, so we decided to extract the 4 incisors, and we decided to do, so this is the day of the extraction with some socket grafting. This was when the implants were placed, and this is when the implants were uncovered 3 months later. And you can see that the bone levels are still relatively where they should be. The patient had the restoration done, was in our hygiene program in our office, coming every 6 months, alternating with her general dentist for up to 6 years. After 6 years, she had stopped coming, and then about a year later, which is about 3 weeks ago, she gave us a call, said she feels like something is loose. And when she came in, this is a radiograph of what happened. There's nothing actually holding the implants in. And you can see here, it's all calculus. She was a smoker. She claimed she had stopped smoking, but I don't know if it was the day she came in or was it a year ago. She claims it was a while ago, but you never know. So at this point, then we actually made the appointment for her to have it removed and grafted, and she called and said it fell off the following day. So she has an appointment now to have the ridge site built and re-augmented and implants all over again. So again, just to show you, this was the day of uncovering, and this is about 6 years later. So it is a big problem. She was a smoker. She had stopped coming for her cleaning. She said it was becoming expensive, so she decided that she would skip a few cleanings, didn't realize, and she thought she had stopped smoking, but I don't know. When you ask them to say you stop smoking, they feel like if they've gone down from a pack to half a pack, that stopped smoking. So that could be the reason why, but it's a big problem that we see, especially in the biologic complications. So let's go into more detail about the biologic complications. So the first one is peri-implant mucositis, which is we defined as a disease in the presence of inflammation confined to soft tissues and no loss of bone. What are the signs? How do we determine that peri-implant mucositis is present? So bleeding on probing or suppuration, which is usually associated with pockets that are up to about 4 to 5 millimeters, not usually more than that. And again, there is no evidence of radiographic bone loss beyond the initial bone remodeling. As far as treatment of peri-implant mucositis, evidence suggests that peri-implant mucositis can be successfully treated if it's detected early and when it's combined with non-surgical efforts. So a European workshop for implant had come up with this protocol. So if you focus just on the top part, and you can see what it says. It's called a cumulative interceptive supportive therapy protocol. And you can see the top part here, which says if the probing depths are less than or 3, and there's absence of plaque, you obviously don't need to treat. If there's plaque or bleeding on probing, you do some mechanical debridement. And up to here, when the probing depth is 4 to 5, this is where you see the mucositis. You do an antiseptic cleansing along with the mechanical debridement. Antiseptic cleansing, according to this protocol, was subgingival irrigation with chlorhexidine, and patient rinsing with chlorhexidine twice a day for 2 weeks. And usually that will resolve the case. So here was a patient that we saw in my practice. Implant was done about 10 years ago, and you can see that there is some soft tissue change there, some redness, inflammation, but nothing marginally, but a little bit below in the attached gingiva. If you see the probing depth is almost 5 to 6 millimeters, so it's a little bit more than what would be considered mucositis. So we took an X-ray to see, but again, on the X-ray, there's no appreciable bone loss beyond the remodeling. So we decided to treat it non-surgically, debrided the area with special curettes made for implants, irrigated subgingivally with chlorhexidine, put him on the protocol for 2 weeks, and then this was a patient, this is actually follow-up of 2 years. And you can see the tissue looks healthy, and it probes about 3 millimeters, and there's blanching of the tissue. There's no bleeding on probing anymore. Another case that we saw, implant was done by another practitioner, has been in place for about 5, 6 years. Soft tissue, you can see inflammation, bleeding on probing about 4 millimeters with severe bleeding. Radiograph shows no bone loss beyond initial remodeling. So again, non-surgical treatment, debridement, chlorhexidine at home and subgingivally, and then this is the result again at about 2 years. How about peri-implantitis? So peri-implantitis is big, and I see a lot. Dr. Nigam mentioned in the beginning, I practice especially periodontics and implant dentistry, and I see a lot. The reason why I say that these implants were placed elsewhere is not because I don't see it in my practice, but because we're getting a lot of referrals from practitioners who do the implants, but they are not sure how to treat peri-implantitis and mucositis. And that's why I'm getting them. And I'll show you my cases too. So it's not that I'm saying it's others, it's happening, it's prevalent a lot. So one of the things was because of the wide variation in the measurement thresholds, we didn't know what the true prevalence was. So Fromm and Rosen were the first ones to come up with a classification system for peri-implantitis. And they classified peri-implantitis into early, moderate, and advanced. And as it shows on the slide, the early, the probing depths were about 4 millimeters more with bleeding and or suppuration on probing, and the bone loss was about 25%. With the moderate, the bone loss was 25 to 50%, and the probing depths were deeper, obviously, as you get more advanced. The key here was that what they did is they standardized from where you measured this bone loss and when you started. So they measured it on the radiographs from the time you put the actual prosthesis in. So that's when you have to measure it. And you use a fixed landmark so you can monitor how much bone you're losing. As far as treatment of this peri-implantitis or peri-implant mucositis is, first of all, you want to make sure you prevent these from occurring. So the way you prevent it is you clear up adjacent periodontal and periapical infections prior to implant placement. And that's a big key. We're seeing a lot more peri-implantitis in patients who have untreated periodontal disease in the same mouth where they're having implants placed. So if they are fully edentulous because of a history of periodontal disease, we don't necessarily see more peri-implantitis. But if they have teeth and those teeth are not treated for periodontal disease, there is a higher risk of getting these complications. So it's important to treat the mouth and make sure that there is no existing disease around them. Also, pre-treatment antibiotics have been suggested, pre-treatment rinse of chlorhexidine, and ideally recall every 3 months after you load the case. If, however, there is established disease, then the therapeutic measures that have been found in literature are mechanical debridement, pharmacologic therapy, some sort of occlusal therapy, and then, of course, surgical therapy. And usually, most treatment involves a combination of these factors. So mechanical debridement usually is using any special hand or ultrasonic plastic instruments. I usually don't like to use the hand plastic instruments because I don't think they really clean anything as well. So it's better to use the metallic instruments that are specifically made for implant surfaces. Pharmacologic therapy, again, is similar to what we discussed before, which is subgingival irrigation with chlorhexidine, possibly systemic antibiotics. Tetracycline fibers I mention it because historically they have used them. They're not available anymore, but they used to use them when they were made. Occlusal therapy is night guard for parafunctional habits. You have to make sure you relieve any premature contacts. And if you find that there is any overload on the prosthesis, then it has to be removed and adjusted or the prosthesis redone. Surgical therapy would, obviously the goal is to clean the abutment and the implant surface and get rid of all the bacteria. And in a rough surface implant, you have to combine mechanical and pharmacologic therapy because you need that. Detoxification of implant surfaces has been proposed in the past using rotary instruments, chlorhexidine, citric acid, and even some sort of laser treatment. So following detoxification, you have to consider whether you want to fill the defect or do you have to resect. And it's important to know that any bone fill that you get, it does not mean that you have re-osseointegrated the implant. And GBR that you perform on these implants it does not yet provide a predictable result. If there is an apical lesion in the implant, if it's asymptomatic, you can monitor it. And if the lesion starts getting infected or expands, then you should treat it aggressively. So then coming back to the first slide that we had shown, if you look at the bottom part now, where the probing depth is more than about 5 millimeters, and you look at a radiograph. You take a radiograph and you see no bone loss, you still do non-surgical. If you see bone loss, then you incorporate other therapies, which is antibiotics and possibly surgery, like we mentioned. So this was one of the first protocols that came out. Subsequently, Dr. Wong and one of his students broke it down into a simpler way is, you see if the implant is mobile. If the implant is mobile, it's failed, you cannot do anything to it, but you have to remove it. If it is not mobile, then you evaluate the bone loss. And if there is bone loss, you look at the extent. And according to them, if it's about half the implant, more than half the implant, they recommend removing it and sort of redevelop the site. If it's less than half of the implant, depending on what it is, you can either try to treat it surgically or you do some non-surgical treatment. And if there is no bone loss, then it's peri-implant mucositis, and then it's non-surgical. They also further broke down surgery into what would you do based on the defect morphology. So if the bone loss was horizontal, you would do what we call an apically positioned flap and do an implantoplasty. If there was a vertical defect, it would depend on the number of walls, just like we do with periodontal disease. If it is a one-wall defect, meaning there's only one bony wall, you have to remove that bony wall and apically position the flap. If there are 2 or 3 bony walls, you can do GBR with some sort of membrane, resorbable or non-resorbable. If it's a circumferential defect, you need to check the occlusion and check the implant position. Once the occlusion is adjusted, if the implant is within the bony housing, then you can do GBR. But if the implant body itself is outside the bony housing, they recommend removing the implant and redeveloping the site. So the biggest challenge always used to be is how do you detoxify this implant surface? Because we knew how to open a flap and how to clean out the soft tissue. We knew how to graft bone, but how do you make sure that that implant is detoxified? So I mentioned before there were a lot of different methods that we used. But again, Fromm and Rosen were the first ones to come up with a case series of 51 treated implants that they followed up to 7.5 years. And as far as I know, they were the first ones to publish in literature a protocol for decontaminating the surface. And their protocol was that once they debrided the osseous defect and cleaned the implant surface with special graphite curettes or titanium tips, they followed this 6-step protocol. The first was application of fine bicarbonate powder for 60 seconds using what they called a ProfiJet. Then they would irrigate it for 60 seconds with saline. Then they applied tetracycline with cotton pellets on the brush for about 30 seconds. Then they exposed the implant again to bicarbonate abrasion. Then they applied the chlorhexidine with cotton pellets for 30 seconds. And then they again re-irrigated with saline that was used in step 2. So this was the protocol that they had developed. And then after all that was done, they either put enamel matrix derivative, which is called Emdogain commercially, to the implant surface, and then the defects were either filled with anorganic bovine bone or a mineralized allograft. And both of these were hydrated with a platelet-derived growth factor. And previous one? You still want that? Sorry. And then this is the other 3 steps. So total 6. Of course, now there's a lot more different protocols that have come out. I'm mentioning this because this was the first one that was well published and followed up for almost 7 years. There are a lot of different ways of doing it now, and I'll go over some, especially also the ones that I'm using. But like I mentioned, the defects were then filled with bovine bone or mineralized bone allograft, and that was hydrated with the PDGF. And then when there was limited connective tissue, they did a subepithelial graft from the palate. Where there was enough tissue, they just used a resorbable membrane. And then, of course, all the incisions were sutured. So this was their protocol. This was their classic case that they had followed for 7.5 years. That you can see here that there is some peri-implant disease. This is a radiograph showing the bone loss in the area more on the distal than on the mesial. This was the case where they opened up, and you can see the bone loss. This is where they're now debrided the whole area, and they're placing the emdogain. This was the graft material that they put in. This was a connective tissue graft that was sutured in place. And this is the radiograph 7.5-year follow-up that they published. So now, having read this lecture and I took a hands-on course, I had a couple patients in my practice that I had wanted to treat but wasn't sure how to go about decontaminating. So this was one of the first patients. These implants were done many years ago. She always had this apical implant lesion that was smaller in size than this, and we were always maintaining it, but it started to grow in size, and I told the patient we need to do something. So you can see here, it wasn't as big, and then it was starting to really spread and affected the adjacent implant. So we told her we need to treat this, and now that I knew, because I just taken a course, I said, I'm sure I can fix this for you. And she was willing to go with treatment, and then this is a radiograph at 5 years of the bone area. And now to see it clinically, this is how she presented. And you can see there's a fistula here at the apex. If you probe though, there's hardly any probing. There's about 4 millimeters on the distal, maybe about 3 millimeters on the mesial. And that makes sense because the lesion is apical in her case. So this was the flap where it was opened up, and you can see this is all soft tissue, granulation tissue. This was removed, and you can actually see the implant. And like I had suspected based on the x-ray, the other implant could be seen through the defect as well. So we filled everything in with some mineralized bone allograft. It's covered with a collagen membrane. And then this was the healing. This clinical picture is also at 5 years when we took the x-ray. This was another patient. The implant was placed, this upper right canine. Implant was placed in another practice. She's a patient of ours for hygiene. Her dentist wasn't sure how to treat it, told her to come to us for the treatment of the peri-implant problem. Here is the probing on the distal. It's about 10 millimeters. Mesial is about 5-6 millimeters. This is a radiograph of what the lesion looks like in 2013. So this was, you see the x-ray. This is 2010 when her dentist had placed the x-ray, and this was 2013, 3 years later. So we decided we had to open up the area and see what was going on. And you can see there's a circumferential bone loss, and there's some cement here. So we cleaned it out, and we told her ideal treatment in this case would probably be doing apically positioning the flap, exposing these threads of the implant, and letting it heal. But because it was in an anterior aesthetic area, she wanted to know if we could do something else. And we told her we could try to graft, but with not so much predictable success. But she wanted us to try it at least before we went to the other option. So that's what we did. We put some graft material circumferentially, covered it with a membrane, sutured it. And then this is the x-ray at 2 years where you can see there is bone fill on the distal. So again, this was when the implant was placed in 2010. This was when she presented to us in 2013. And then this is the x-ray about 2 years later. And she's still maintaining. Another patient we saw in our practice, and coupling defect on the mesial implant, was treated with a graft, and this is a 1-year follow-up, where you can see that it's still remodeling here. It looks like it has kind of filled in here, maybe not as much. So let's talk about the sequence of treatment. You want to establish any possible iatrogenic factors: excess cement, over-contoured prosthesis, any malpositioning of the implants or other factors. Floss remnants or cord. And I've removed both when I've removed a failed implant, where I saw cord wrapped around it. So I'm hoping I don't restore, but for most people who restore that I've spoken to, they don't use cords anymore, for implants at least. So I hope you don't, and if you do use it, make sure you remove it after the impression, because I've had removed 2 implants where there was cord packed on it. So let's talk about cements, because that's a big problem. That's a huge problem. If any of you get a chance to listen to Chandru Wadhwani, who's a prosthodontist based out of Seattle, just listen to him. He has great tips, he speaks well, and he has a lot of information on why cements are becoming a big problem. So this is one of his cases in his book that he shows. But he also gives a lot of tips on what to do. So the biggest complaint sometimes is that how do we clean up all the cement? And this is one of the suggestions that he gives, is that before you insert the crown, at the visit of the insert, you make a mock replica of the inside of the crown, which almost looks like the abutment that's in the patient's mouth. You put the cement in the crown, and you actually place that crown on this replica that you just made, so you get all the flash to come out extraorally. And then you take this and immediately put it in the patient's mouth. So the amount of flash in the patient's mouth is not as much. So it's minimal, hopefully it's easy to clean. The other complaint usually with screw retained restoration is that there is an occlusal hole, it looks dark, it looks black. And unfortunately, at least the dentists that I know of in the US use shade probably like D20 to put on top, so it never matches the shade of the crown. So his recommendation is that you can offer this to the patient, which is a porcelain inlay that can cover the access hole. So there are some choices. But this is a big problem, and I'll show you just a few cases that I've had. This was a patient, furcation involvement, but we were maintaining it for a long time. Then she started losing bones, started getting soft tissue problems, and we told her that if we don't act fast, we might not be able to put an implant in because of the inferior alveolar nerve proximity. So she decided, she agreed. We took the tooth out, we put an implant in. 3 months later, we put a healing abutment. The restorative dentist wanted us to contour it better, so we changed the healing abutment. She went to have the restoration done, and then she came back for her cleaning 3 months later, and this is what it looked like. So this is 3 months post-restoration. So I looked at it, no mobility. She didn't have any complaint except that she thought that there was more food getting impacted there. So I told her, I said, we need to treat this. This is, we have to open it up and see what's going on. The good news I told her was that the implant is not loose, so hopefully we'll be able to graft around it. I'm not sure how successfully, but let's at least try and do something. We can't leave it. She agreed. She was busy. She said she'd schedule an appointment after a few months. She wasn't able to, and then she came back after 3 months from this date to have her cleaning done, and we took the x-ray, and you can see what it looks like. So we had to extract at that point, explant, and then we had to graft again. So again, this was 3 months after restoration, and this is about 6 months after the restoration is in place. And at this point, it was mobile. So we had to explant, and this is what it looked like. And you can see all the cement, facially, interproximally, even inside the crown. It's a big problem. So this is what the day we explanted the cone beam section, and this is 4 months later, cone beam, to see how it's healing. Probably going to wait another 4 more months before we take another scan to see if we can place the implant in. One more. This patient was referred for the peri-implant problems in this area. But the other problem also was that this crown kept coming off. So the dentist thought that there was some soft tissue impinging on the abutment. But when I took the x-ray and I saw this, I told them that we need to treat this and leave the crown out while it's still healing. It's in the molar region, so maybe wait another 3-4 months till I'm sure that everything is healed. So we opened it up, we did the grafting in this case, and we saw this result of healing. This is about 4 months after the surgery. So I told the patient that now you can go ahead and get the crown placed. She had the crown done, and she came to me about 2 months after the crown was done, saying that she feels like the crown is loose again. So I had her come back to the practice to take a look, and this is what happened. Look at all the cement. Circumferentially, cement. And we're seeing, there's case after case that we're seeing. I know I'm restricted with time, so I want to make sure that I go fast and not show you. I'm not going to show the whole video, but this is one that's on YouTube that I've taken it from. And he speaks about cements. So make sure, if you get a chance, you go and watch that. It's very important. It's a very brief sort of adaptation of his actual lecture, which is almost like a half a day. But it goes over what you should do, why cements are a problem, and what you should keep in mind when you're cementing, if you're going to use cementable. So the sequence of treatment is you assess and diagnose, reduce the risk factors, obviously. Biggest ones, poor oral hygiene, smoking, diabetes. If required, you remove and adjust the prosthesis. And then non-surgical debridement with biofilm removal and antimicrobials as needed, and you reassess in a couple months. If the disease is resolved, it was probably mucositis, and you're fine. If it has not resolved, then you need to go with a flap. A flap removes the granulation tissue, and then you decontaminate. Like I mentioned before, initially we didn't know, but Fromm and Rosen came up with the idea of decontamination. Subsequently, there are a lot of different ways, and one of the ways that we are using now is using the laser. And some of those techniques, you don't even have to raise a flap unless you want to graft. So I'm just going to show you a little animation. So I'm going to stop talking and let the slide talk. So this is BioLace, which is available, and it's an erbium YAG laser. You cannot use a diode to do this. It has to be an erbium YAG or an ND YAG. So I'm just going to go a little faster. The key is to use the laser. They have a special tip which fires radially. And then they have another tip that actually debrides the actual threads of the implant. So that's the advantage of this laser. This is a protocol with another laser made by a company called Millennium. It's an ND-YAG laser, but their philosophy is also similar, and there's no flaps raised in either of them. You just go intracellular, you clean it out, you allow for clot to form, and you let it heal, and you get bone regeneration. And this is one of the cases that Dr. Scott Manhart, who speaks for the company, has mentioned. He had a patient who came in 2015 for this bone loss. He used that protocol that I just showed you. It's called LePIP, which is a trademark for laser-assisted peri-implantitis protocol. And you can see in 2019 that he had bone growth. So it does tend to work well, but it's not always a guarantee. So to continue with the surgical access, once you've debrided the area, you decide, do you want to regenerate? In which case you have to fill the defect with bone or some sort of bone substitute. You possibly have to put a barrier membrane over it. And whether you submerge it or not depends on what kind of defect you had. And that's what will decide what you'll do. If you decide to do a resective approach, you have to recontour the bone like we mentioned before, and then apically position the flap, and you can make a decision on whether you want to leave the threads as is or you want to do implantoplasty. Just remember, if you do implantoplasty, there's a lot of sparks in the mouth and the chance of all the metal getting incorporated into the tissue. So a lot of times if you think the patient is good with their home care, because now that the implant is exposed and they can brush it, you may want to just leave the threads. Also, immediately post-operative, you want to give them chlorhexidine to rinse twice a day for 2 weeks. And depending on the complexity of the procedure, you may want to put them on some sort of systemic antibiotics. As far as supportive therapy is concerned, you want to monitor it clinically. And if you see anything where you suspect some sort of disease, you need to take a radiograph, because we discussed before that peri-implant mucositis will not show any appreciable bone loss, whereas peri-implantitis shows obvious bone loss. So you must take radiographs. You go over home care instructions with the patient always, and ideally you want to see them every 3 months for a cleaning. I don't do it in my practice, but I know a periodontal practitioner who says that if they guarantee the implant if the patient comes to them every 3 months for a cleaning. If the patient doesn't come every 3 months and something goes wrong, they have to pay for the implant. So it depends on your practice, but I know some people who've done that too. So one of the things is very important for you to remember is that removing an implant is an option and you must consider it. And the factors that will influence this decision that you make is what is the severity of the lesion, what's the position of the implant, what do the surrounding tissues look like. And if you think that by treating it, the outcomes are likely to be unsatisfactory, you may want to remove that implant. Conclusion is that treatment of peri-implantitis is still a challenge, and there's no one proven method that's predictably successful. And if the implant has failed, you have to remove it. You also have to advise the patient that soft tissue recession should be expected following this treatment. And progression or recurrence of the disease may still occur, and they may need additional therapy or even possibly implant removal. So the case study that was published by Fromm and Rosen, where they followed up the patients for 7.5 years, they had about 6 patients that needed 3 different surgeries to achieve the desirable result. So it's important to remember that sometimes one surgery alone may not be enough. As we mentioned before, I'm a periodontist first, so I try to save teeth as much as I can, and when I can't, then I do implants. And anybody who's a periodontist in the audience probably knows that there are classic periodontal maintenance studies that were carried out in private practices, which showed that they had 77 to 83% of the patients well maintained for almost up to 50 years. And we know that because there's a systematic review done in the Journal of American Dental Association on whether we should preserve the tooth or place an implant, and what are the long-term survival rates. And they showed that the implant survival rates do not exceed those of compromised but adequately treated and maintained teeth. And we know this also from historically from, especially coming out of University of Pennsylvania, who had the PERI-IMPLANT programs, where some of the people that we read about in our periodontal literature, Arnie Weisskopf, Lenny Abrams, they have these what they call PERI-IMPLANT cases, where if you look at the x-rays today, most people in the audience would probably say, take all the teeth out and let's do an all-on-4. But they've maintained those patients for almost 40 to 50 years. So we do know that with adequate maintenance, you can treat them. The decision to extract a tooth and to place an implant must be made very cautiously. Even when a tooth seems to be compromised and requires treatment, implant treatment might also require additional surgical procedures that might pose risks as well. So you have to keep that in mind before you just flippantly decide to take the tooth out and place an implant. And a tooth can be extracted and replaced at any time, but once it's out, it's an irreversible procedure. So I'd like to leave you guys with this thought. When you're dead, you don't know that you're dead. It's difficult only for the others. And it's the same when you're stupid. So don't be like that. Think about what you're doing. Base it on science. And I thank you very much for giving me this opportunity. I want to thank especially Udat and Ali for recommending that I speak here, and to the organizers for all the confusion I caused, and they were able to manage my schedule, and to Dr. Kothare, who kindly agreed to speak instead of me, because some of you may have noticed that in the brochure, my name is yesterday, and today was supposed to be him. But he took one for the team, and he took one for his old student, so I thank him for that, and I thank you for your attention.